Hey guys, today we're gonna be speaking about the renal drugs. Most of them are like diuretics, so we're gonna be speaking about mannitol. So this is gonna be basically osmotic diuresis to increase serum osmolality. This causes fluid from the interstitium to intravascular space. It basically causes more urine flow, and this was really good for decreasing your intraocular pressure and intracranial pressure. So as you can imagine, this is very good for increased ICP or any type of glaucoma. It can really treat glaucoma pretty well. So yeah, we can drug overdose, increase intracranial intraocular pressure. The problem is it can cause dehydration, which is as we know it can be used for, it can cause dehydration. We can see it can cause hypo or hypernatremia. Now that's where it gets a bit tricky because initially you may have hyponatremia because you have too much water in the blood, but later you might get hypernatremia because you're diuresing too much. It can cause pulmonary edema. That's because the increased osmolarity, this puts pressure on your pulmonary capillaries. It's contraindicated in heart failure. Of course, we have too much blood, and also anuria because we cannot eliminate the fluid from the body. Next is acetazolamide. Guys, acetazolamide is a carboanhydrase inhibitor. When we inhibit carbohydrase, we're not able to form a bicarb plus hydrogen. Those are really two important molecules. So basically, it causes sodium and hydrochlorothiazide to so carbon anhydrase essentially doesn't allow a hydrogen plus bicarb to make H2CO3. So we get too much bicarb, and that connects with sodium, and that kind of diuresis, and that also alkalizes the urine, but it acidifies the body in that sense because you're losing bicarb. So it's good for glaucoma. It's good for treating metabolic alkalosis. It's also very good for treating, if I'm not mistaken, high acute mountain sickness because you're going to get acidemia in the blood, and that's going to trigger hyperventilation. That's going to treat your acute mountain sickness, altitude sickness, idiopathic intracranial hypertension. Because acetazolamide essentially decreases the CSF production. One of the things in the chloride, for some really weird reason, is that you need a chloride is a part of the CSF. I'm not too sure what's going on there, but it can be there. It's a key component over there. Then we can see over here the paroxysmal renal tubular acidosis type 2 renal acidosis. As we know, type 2 is going to be the proximal one. Type 1 is it's going to be one, as in you can remember one as in ONE as in bone. You can also learn one it's going to be distal, so DCT. Not DCT, it's going to be in the collecting tubule. And the number 2 is going to be in the PCT. So we're going to get adverse effects in paroxysmal renal tubular acidosis. It can cause paresthesias because acidosis can mess up the electrolytes. It can get sodium hydroxide toxicity. Now, this is really important. So essentially, you're going to be in your urine. Essentially, what happens is the proximal tubule. Basically, we're going to be, when you inhibit carbon you're decreasing the amount of hydrogen being secreted. It's going into your body, and now your urine is going to become alkali. The more alkali, it kind of converts NH4 plus into NH3, and which is diffusible, so it can come into our body. It can cause a lot of problems. So we want to be careful here because we want to keep NH4 high. Then we can see sulfur toxicity, hypokalemia, and ProHeart calcium phosphate phone because it's going to be, you can imagine that the urine is really alkali, so it can easily lead to a stone. It involves PCT primarily, to be honest. I just want to come over to the renal tubular acidosis. So as we spoke about, this can be it can cause type 2 renal tubular acidosis. That's because we're essentially type 2 is 2, so you're going to be losing bicarb, and you're going to be getting a normal iodine gamma metabolic acidosis. So type 1, as we spoke about, it's going to be there's going to be a defect in our distal, which is going to be in our alpha integrated cells. So we're of course going to be secreting we're not going to be secreting hydrogen ions, and we're going to be getting too much hydrogen ions in the body. And 2 is we're going to be secreting bicarbonate. Number 4 is of course hypoaldo. Coming back those were the principal cells, alpha integrated cells. Sorry. Coming back into the I believe we're going to be doing the loop diuretics. So loop diuretics, they essentially act on the descending loop of Henle, and they were going to be decreasing the amount of sodium, potassium, 2 chloride. you're going to be losing them. You're going to get in diuresis. Another really good important fact of furosemide is that it increases your prostaglandin. So it increases vasodilatory prostaglandin is going to be increased. So you're going to be getting vasodilatory effect on the afferent arteriole. So that's going to be quite useful over here. And it's going to be inhibited by, of course, NSAIDs. So you can get calcium is going to be excreted. So calcium loop loses. Okay. So of course we're going to use an an edema state. So heart failure, pulmonary edema, all these terrible states, and of course hypercalcemia, because we can use that, and also high blood pressure. Guys, the toxicity is O bang, so O as an O toxicity, H is a hypokalemia because you're losing fluids, so you're losing potassium. The other H is hypomagnesemia, you're losing magnesium as you're losing fluids. D as in dehydration, you're losing fluids. A as an allergy, so it can cause allergic problems in your body, like sulfur allergies. And then N is going to be nephritis, so you can call it acute interstitial nephritis, so you can get many things over there. And then you can also going to cause gout, so you can prevent the release of uric acid, so you can get gout. Either chronic acid gout is the same thing, but just given to patient who has sulfur allergy. Thiazide is going to be inhibiting the sodium chloride symporter at the apical part of DCT. So that's the sodium chloride, and so when you inhibit the sodium chloride, you're getting more sodium chloride going to the body. Then you have another channel over there which has sodium going to the body and calcium coming to urine. That too is not going to be functioning, so you're going to get hypercalcemia in the body. But that's really good if you're getting calcium stones. It can, as we can say, it's going to be, you lose fluids, so you're doing hypertension, heart failure, IDP, hypercalciuric, nephrogenic diabetes insipidus, and osteoporosis. Now, why would it help in nephrogenic diabetes insipidus? Is going to be because the thiazide, basically they reduce urine volume. When we're reducing urine volume, we're getting volume depletion, and that stimulates the proximal convoluted tubule to reabsorb sodium and water, and that diverts the fluid from collecting from the defective collecting tubules. So essentially, as we know that the nephrogenic diabetes insipidus, we can't reabsorb water. So you're going to be essentially stimulating a low volume, and your body's going to be doing a really interesting thing, is going to reabsorb from the PCT. So that's really important. Side effects are more or less the same: hypokalemia, metabolic alkalosis, because you're of course losing fluids, so you're activating RAS, so you can get metabolic alkalosis. Hyponatremia, hyperglycemia, hyperlipidemia, uricemia, kind of similar to furosemide in that sense. Hypercalcemia, as we spoke about. Potassium sparing diuretics is going to be your SEAT, so spironolactone, eplerenone, amiloride, and triamtine. Remember the first two, spironolactone and eplerenone, they act on your aldo receptor, and amiloride and triamtine act on your ENaC, which is going to be in your principal cells of the collecting duct over there. We can see over here the use of this is going to be in hyperaldosteronism. In hyperaldosteronism, we're going to get a lot of aldosterone, and that leads to negative feedback on your renin and angiotensin, on your ACTH as well. So over there, ACE inhibitors have no use. So that's a very tricky thing. They asked this in NBME number 9. So be careful if you're doing that question in NBME number 9. We can use this for heart failure, hepatic ascites, nephrogenic diabetes. We can also use for nephrogenic diabetes because why? Because you block ENaC. You're essentially preventing sodium from entering the principal cells. By sodium collection, lithium accumulation, you're preventing nephrogenic insipidus. Guys, the side effects are more or less pretty relaxed. Let's come into urine sodium chloride. All diuretics increase that. Potassium, most of them increase that, apart from potassium sparing diuretics. Blood pH, guys, these two cause acidemia. Carbonic anhydrase inhibitors, because you're accumulating hydrogen, and potassium sparing. The alkalemia or loop and thiazide, because you're losing volume, so you're going to be activating aldo. That's going to be the reason. So this over here is very interesting. Loop loses, so you're getting more urine calcium, but thiazide are going to be you're going to get increased body calcium. So those two are opposite in that sense. Then we have ACE inhibitors over here. So ACE inhibitors, they prevent lead to less angiotensin 2, that decreases GFR, and that would lead to an increase in renin due to loss of negative feedback. So inhibition of ACE. When you inhibit ACE, ACE is involved in breakdown of bradykinin. So when you inhibit that, you get more bradykinin. Same with neprilepsin. Neprilepsin breaks on bradykinin, so you get more bradykinin, which can be beneficial, but it can lead to angioedema. A C1 esterase inhibitor deficiency. C1 esterase makes bradykinin. Our body has an inhibitor. So C1 esterase makes. We have an inhibitor on that. We can have a deficiency of that can make too much bradykinin. We can have hypertension, high heart failure, protonemia, diabetic retinopathy, prevention, unfavorable remodeling, and chronic hypertension. In CKD, diabetic nephropathy, it decreases glomerular pressure. Guys, what's the side effects? Catch. So cough, angioedema, tetragenicity, creatine can get elevated, can get hyperkalemia, and we can get some sort of hypotension, of course. Don't use this with bilateral renal stenosis because you're going to have already RAS is going to be elevated in that. ARBs are basically the same thing, just remove the cause side effect. Yeah. Aliskiren, the same thing. Aliskiren kills renin, so it decreases your renin. Used for hypertension, and it can cause hyperkalemia and this. So that was the renal drugs. I hope you found this very useful, and hope to see you guys next time.